Hello, everyone. My name is Michael Rextis, and this is my clinical reasoning project. So to begin, I want to give a brief overview of this patient. She's a 56-year-old female with a past medical history of bipolar disorder, anxiety, depression, insomnia, and chronic pain. She ended up um, presenting with manic symptoms. The staff had identified that she was acting strange while visiting her family member who was in the emergency department. So they ended up asking her if she would be checked up, and that's how the case started. Her chief complaint was, "I cannot sleep, and my mind will not stop going." So a little brief history of the presenting illness. Again, her past medical history is listed up there, and then no known family history for this patient. Current medications is she's on duloxetine 80 milligrams PO daily and Wellbutrin XL 150 milligrams PO daily. As you can kind of see already, she's not on a mood stabilizer, and we'll get into this more as the presentation goes on. But that was one of the main concerns when we first saw this patient and seeing her in the presentation that she was in. Her vital signs were within normal limits, nothing irregular there. When we were actually consulted to see this patient because she was medically admitted. We'll get into that a little bit more. But one of the precipitating factors that seemed to be contributing to some of her symptoms was some stress in the family. Her mother was not doing well, living in an assisted living, and she had an injury and just was declining, and hence why she was at the ER. So this patient was actually visiting her mother, who was at the emergency department, when staff saw that she was exhibiting some signs of mania. So they asked her to be evaluated. So that seemed to be the main factor that was contributing to a lot of the patient's anxiety and posing a lot of psychosocial stressors on her. So when we evaluated her, she presented with some rapid and pressured speech. She was moderately tangential, requiring frequent redirection. She had an expansive mood. She was very liable at times, laughing and then crying or laughing inappropriately about things that she was talking about. She endorsed some sleep disturbances, not being able to sleep for the last couple of days, increased energy, feeling just kind of some of those generally elated, but she just could tell that she was not herself. She wasn't able to control what she was saying. She was just kind of all over the place. She endorsed some impulsivity with poor judgment. She talked about wanting to go drive and potentially not understanding the consequences of that, but then kind of joking about it then afterwards. So just things that weren't really lining up. Her insight was fair. She realized that she was experiencing a manic episode. She was able to tell us that this was pretty congruent with previous episodes. And as we talked with her more, we ended up discovering that she ends up having these episodes once every couple of months. So she knows pretty well of what they are like for her. So a little bit more of some background on this patient of why I wanted to present on her. When we assessed her, she had mentioned that she did see an outpatient provider, but the outpatient provider, see if I can go back, the outpatient provider was treating her for depressive symptoms and wasn't too certain that she had bipolar disorder. Well, per the patient, she never presented an acute mania or hypomania, or whenever she was feeling better, she decided not to go see her outpatient provider. So she said she would only present when she was feeling depressed. So when we reviewed the outpatient provider's notes and things like that, it just kind of outlined this major depressive disorder and didn't really show the fluctuations in mood that we will commonly see with people who have bipolar disorder. Um, so that just is a little point to really ask poignant questions to these patients to really make sure that we're assessing thoroughly the cycling of their moods and making sure that we're not missing something because sometimes in those small appointments, we don't have time to go into super in-depth detail, especially when we may believe that we know the patient and their presentation already. And she had been her bipolar disorder was going untreated, and also her presentation was skewed because she was only presenting when she was feeling low and not when she was feeling up on a high or however you'd like to put it. So I thought that that was interesting and a good learning point. So the diagnostic workup. So it consisted of a urine drug screen, ethanol level, thyroid panel, CBC, BMP, urine analysis, and then a head CT was considered. She had a full medical workup done. The medical workup ended up showing that she had an acute kidney injury. They thought that this was due to some dehydration. So she was medically admitted for the acute kidney injury, and psychiatry was consulted to see her for the manic symptoms. Her urine drug screen was negative, ethanol was undetectable, thyroid panels they didn't show any hypo or hyperthyroidism. The CBC and BMP, the BMP showed some kidney injury with elevated creatinine, and the urinalysis was unremarkable. So they weren't too considered for an infection. Nevertheless, she ended up getting fluids and was medically admitted. So collateral was obtained through chart review from the patient's nurse. And then also we spoke with the patient's outpatient mental health provider to just get an idea of how the patient has been doing recently. And we kind of got the same gist that I kind of expanded upon that she was presenting in lows, and then we informed the outpatient provider about her talking about how she sometimes how she doesn't like to go when she is feeling more manic or hypomanic. Um, per the patient, her hypomanic or manic episodes would last for a few days, and she would usually just kind of stay at home and keep to herself when they occurred. A differential diagnosis for her would be substance-induced psychosis / substance-induced mania, an exacerbation of her bipolar disorder with the current state of being manic, mania induced by a medical or organic cause. We could have some unspecified anxiety disorder, unspecified depression with psychotic features, or an exacerbation of her insomnia. So all of these things were considered. Given her presentation, we were able to rule out substance-induced because there weren't any substances. She didn't endorse excessive caffeine use, which can at times exacerbate mania just through being stimulating and also affecting sleep and your circadian rhythm and so forth. She did endorse poor sleep chronically, which can be a risk factor for mania, as we know, as a circadian rhythm that's off can increase your risk of mania and so forth from insomnia. She presented with some symptoms of anxiety, so we wanted to identify any factors that are making her anxious, and kind of as talked about with the precipitating events, being that her mother's not doing well, that was making her very anxious and kind of feeling irritable and on edge at times. But the way that she presented with the manic symptoms was not just an exacerbation of an underlying anxiety disorder. And then depression with psychotic features. Although she did present tangential and disorganized at times with how she was speaking, she did have a history of bipolar disorder, and she didn't endorse any hallucinations or things like that. And I think it's also important to say she didn't endorse any suicidal ideation or homicidal ideation, and that the main concern for her safety was the current state, her current manic state, and her lack of her poor judgment, and then uh, fairly poor insight. And then we didn't end up doing a head CT. This wasn't the first time she'd been manic. She denied falls. But if things were to progress and her presentation wasn't going, didn't improve or worsen with the treatment of her mood with antipsychotics, then we would have gotten a head CT to rule out any organic causes such as a tumor or things like that. As I mentioned, the thyroid studies didn't show anything, so we weren't concerned about hyperthyroidism or another medical cause causing her elevated mood and symptoms. So a little brief discussion on the pathophysiology. Substance-induced is one of the main reasons that we see people with who present with manic symptoms, right? So this can be from alcohol withdrawal, it can be from stimulant use, such as amphetamines, cocaine. It can be from either using something or withdrawal from a depressant medication like benzodiazepines or alcohol or opioids even. I had a patient who ended up getting psychosis from opioid withdrawal. She was totally normal and then all of a sudden stopped taking her opioids because she wasn't, they weren't prescribed as they should have been in the hospital. She'd been taking them chronically and she ended up being psychotic, which was very unusual for her. Once we got her back on her opioids, she was fine. So those are things to consider if people are using substances chronically and they're no longer getting them, or if they're potentially using, then those are things to look out for. A lot of these pathophysiologies of these disorders are poorly understood. The idea is that there's a dysregulation between the brain's ability to cope with stresses, both biological and psychosocial stresses, and then that increases one's susceptibility to getting a mental illness. Anxiety, we're looking at heightened HPA axis activity with your amygdala and things like that, and stress response, the sympathetic nervous system being an overdrive more chronically, which can cause you to startle easily or be anxious. Insomnia, there are multiple causes for insomnia. Some of them are just poor behaviors that lead to poor sleep habits, affecting, you could have issues physiologically in your brain as well that lead to insomnia, but a lot of the cases of insomnia are due to people using their technology at night, not having a sleep schedule, or not spending time doing the things that they need to do to support their circadian rhythm, eating well, getting up in the early, being exposed to bright lights early in the morning, and so forth. And then other medical causes, hyperthyroidism is one of the main causes of that can induce mania. And so this would be overactivity of the thyroid, leading to increased thyroid hormone, and the thyroid is responsible for metabolism. So if you have too much thyroid hormone, you're going to increase your metabolism, speed up your systems, and you can potentially have manic-like symptoms. So the treatment and plan for this patient. So we initially gave her a one-time dose of quintiapine 25 milligrams PO for her manic symptoms. The reason we chose quintiapine was because it's an antipsychotic medication that works as a mood stabilizer and it works fast. We didn't want to do something like lithium or lamotrigine or anything like that because those take time to work, where antipsychotics like quintiapine can work more rapidly to help the patient's mood. So after that one-time dose, we also then scheduled her while she was admitted inpatient for medical for 25 milligrams PO nightly to help with her sleep, as quintiapine is oftentimes sedating for patients. So this could also help with her insomnia and then mood. We also wanted to start at 25 milligrams, even though it's a low dose. We wanted to start there so that we could titrate it up as appropriate. Um, it's best to start low and go slow to limit side effects, and also to find the lowest effective dose to decrease that medication burden on patients. We wanted to we held the duloxetine and the bupropion during her acute mania, and then we considered restarting once she was no longer manic. It's not great to have those stimulating medications on for her, especially with no mood stabilizer, as duloxetine increases serotonin and norepinephrine, and Wellbutrin increasing norepinephrine and dopamine. Those can be very stimulating medications that can be very helpful for motivation, concentration, helping with her chronic pain with the duloxetine, as duloxetines can be used for fibromyalgia, chronic pain issues, neuropathic pain, things like that. But the issue then becoming that it can induce mania. That is kind of a difficult place to be if those medications were really helping her to do the things that she needed to do. It may be considered, it may be okay to keep those on and closely monitor as long as she's on a mood stabilizer. But really, we wanted to defer that to her outpatient provider to manage those medications more and get her in a better spot, being that they would be able to check up on her long over a period of time. We started her on melatonin, 1 milligram PO nightly for 2 weeks for sleep. Having a dysregulated circadian rhythm, as mentioned, can increase one's risk for mania. So melatonin does really well at helping our brains and body get back on a schedule. So she should take this 30 minutes to an hour before bedtime at night at the same time, and that will help reset her circadian rhythm. And then it was found out through talking with the patient that she had in the past been on lamotrigine, and it had helped her. She was no longer taking it. She wasn't able to tell us why she had stopped it. Oftentimes, patients will stop taking lamotrigine because of a rash that develops, as Stevens-Johnson syndrome can be life-threatening and can occur with lamotrigine. So we really wanted to be kind of tentative about this and needed to gather more information from our outpatient provider and her records. So we weren't too sure about starting lamotrigine, but if we were going to, we would start at 25 milligrams daily, and then you'd have to titrate this up slowly and monitor for a rash. It's more likely for patients to have rashes within the first 8 weeks of initiating the medication. You can get delayed rashes as well, but you really want to be cognizant of that when first starting it. Any rashes in the face, things like that should be stopped immediately. Any rash really when you're starting lamotrigine should be stopped immediately and investigated. And you can use a more immediate acting mood stabilizer while you're titrating as well. So, for example, you could keep Seroquel on while you're titrating up lamotrigine to a therapeutic range to help the patient, so that they're still covered mood-wise. So we would cross titrate lamotrigine and keep Seroquel on for the time being until the patient was within a higher range of lamotrigine. And then some non-pharmacological options would be keep a day and nighttime routine, provide a low stimulating and calm environment for the patient. We really want to get a good sleep schedule going, consider cognitive behavioral therapy for insomnia, and then also could do some cognitive behavioral therapy for bipolar disorder, helping her to identify when she's flipping into a more elevated mood, things that she can do to cope better, and then building good routines to keep her out of the hospital. Some brief additional considerations. Health promotion, we want to prevent disease, and we want to keep the patient treated with her medications and on them consistently. The current understanding of bipolar disorder is that it's a lifelong illness and that there is usually some risk of relapse. So making sure that the patient is on a mood stabilizer and understands the benefits versus the risks of that, and discussing that with the patient. Some cultural considerations. It's important to understand how the patient's culture views the use of uh, mental health medications and mental health in general. Some people, some cultures view mental health one way versus one of the other, and that can also lead into stigma developing as well. So um, it's really important to meet the patient where they're at and to support them in their decisions, and to make sure that we're offering them, providing them the opportunity for informed consent and going through things with them. And then other ethical considerations, we didn't end up feeling like it was necessary to admit this patient um, to the psychiatric inpatient unit. After we'd given her the Seroquel, she had calmed and was able to sleep, and then she ended up sleeping all night and was able to sleep most of the day, and her mood and her tangential speaking and language and disorganization kind of vanished, and she was doing a lot better the following day when we reassessed her. So ethically, it didn't see we weren't going to be able to hold her involuntarily, nor should we have. So that's important to reinforce patient autonomy and make sure that safety is addressed. And then again, the outcome. She ended up doing a lot better after we gave her the Seroquel. It worked well. It helped her sleep at night, and she ended up feeling a lot better. We followed up with her the following day. The medical team had cleared her and she was discharged. So we communicated to follow up with her outpatient provider that week. We made sure that there was an appointment scheduled, and then we sent her. I can't remember exactly what we sent her with, but I think we might have just kept her on the Seroquel and then asked her to follow up with her outpatient provider. We decided not to restart the lamotrigine just because we weren't sure of the response and why she was stopped on it in the first place. So we sent her home with the Seroquel. And I want to say that we ended up deciding to restart the duloxetine and bupropion, and told her to take those with caution because she had been taking them for a while and it was helping her. So now that she was on the mood stabilizer, there was a lesser of a risk of her relapsing, but still that risk was there. And it's important, again, to treat the depressive side. Um, and that being said, Seroquel is a medication that's approved for depression and mania, for the treatment of bipolar disorder. So that alone could be sufficient. But given that she was on Wellbutrin and duloxetine chronically for a long time, we felt more comfortable having the outpatient provider manage those more. And then here are my references. I appreciate all of you for listening, and thank you, and have a great weekend.